Welcome to Recognition of Prolonged QT Interval in Adolescents, a practical guide for nurses and clinicians. This course has been created to enhance your confidence and accuracy in identifying prolonged QT intervals in adolescents, a critical yet often misunderstood area of pediatric and adolescent ECG interpretation. Over the next two CPD hours, we will explore how to recognize normal versus prolonged QTC values, understand correction formulas, identify red flags, and apply a structured, evidence-based approach to interpretation and escalation. Who should take this course? This course is specifically designed for healthcare professionals who encounter adolescent patients in clinical practice and may be responsible for interpreting ECGs. It is particularly relevant for registered nurses in pediatric and adolescent settings, pediatricians and pediatric registrars, emergency department clinicians, general practitioners who manage teenagers and young adults, clinical educators building ECG teaching resources, rural and remote health workers without on-site cardiology support, medical students and junior doctors building ECG confidence. These clinicians are often the first point of contact when an adolescent presents with syncope, palpitations, or other symptoms that may require urgent QTC assessment. Competence in distinguishing normal from prolonged QT intervals ensures timely escalation and safer care. Why this course matters. Recognizing prolonged QT in adolescents is clinically critical because misinterpretation can have life-threatening consequences. QT prolongation is a risk factor for torsade de pointes and sudden cardiac death. Yet, many nurses and junior doctors are uncertain when QTC should trigger escalation. Another source of confusion lies in the correction formulas, Bazette versus Friedericia, which often produce different values, especially in cases of tachycardia or bradycardia. Misapplication of these formulas can result in overestimation or underestimation of risk. This course will equip you with the ability to recognize normal versus prolonged QTC values, considering both age and sex differences, understanding of correction formula strengths and limitations, recognition of clinical red flags that require urgent action, confidence in managing drug-induced QT prolongation, a structured framework for applying knowledge in practice. By the end, you will have practical skills to interpret QTC safely and escalate appropriately. Module 1: Introduction to QTC in Adolescents. In this module, we will explore why QTC measurement is so important in adolescent care. The QT interval represents the time taken for ventricular depolarization and repolarization. Prolongation indicates delayed repolarization, often linked to ion channel disorders or congenital long QT syndrome, LQTS. Adolescents are particularly vulnerable to QTC-related risks for several reasons. Puberty introduces hormonal changes that affect cardiac electrophysiology, with differences emerging between males and females. Athletic screening often uncovers borderline QTC values, leading to clinical dilemmas. Nurses in ED and ward settings may be the first to encounter prolonged QTC, but lack formal training in adolescent-specific interpretation. This module will also introduce the common challenges faced in nurse-led ECG interpretation, including difficulties with formula choice and uncertainty about thresholds for escalation. Module 2: QTC correction formulas and pitfalls. Accurate QTC measurement requires correction for heart rate, but not all formulas are equal. Bazette's formula, QTC equals QT divided by the square root of RR, is the most widely used, but tends to overestimate QTC in tachycardia and underestimate in bradycardia. This makes it less reliable in adolescents, who often have higher heart rates than adults. Friedericia's formula, QTC equals QT divided by the cube root of RR, is more accurate in children and adolescents, particularly at extreme heart rates. Framingham's formula offers another alternative, often closer to true values than Bazette. You will learn step by step how to manually calculate QTC and compare outputs across formulas. Case examples will demonstrate how the same adolescent patient may show a borderline QTC with Bazette, but fall into the normal range with Friedericia. By the end of this module, you will understand which formula to use in different scenarios and how to interpret discrepancies between them. Module 3 – Normal versus Prolonged QTC in Adolescents. This module focuses on what is normal, borderline, and prolonged. In males, normal QTC is less than or equal to 450 milliseconds. In females, normal QTC is less than or equal to 460 milliseconds. Borderline values, 450 to 480 milliseconds, require careful consideration of context. Prolonged QTC is greater than or equal to 480 milliseconds, with greater than or equal to 500 milliseconds considered high risk. You will learn how to interpret these thresholds in light of family history, syncope, and other red flags. For example, a QTC of 470 milliseconds in a teen with unexplained syncope should be taken more seriously than the same QTC in an asymptomatic adolescent. We will also review how to avoid over-interpreting borderline QTC without context, balancing vigilance with clinical pragmatism. Module 4 – Clinical Red Flags and Escalation Pathways. This module identifies red flags that demand urgent review. Symptoms include unexplained syncope, palpitations, seizures misattributed to epilepsy, and a family history of sudden cardiac death. You will learn guideline-based thresholds for escalation, QTC greater than or equal to 480 milliseconds, requires review and often cardiology referral. QTC greater than or equal to 500 milliseconds, urgent escalation, even in the absence of symptoms. We will review how to communicate uncertainty effectively and use a stepwise escalation pathway for ED and ward settings. A flowchart will guide you from recognition to referral, ensuring patient safety is prioritized. Module 5 – Drug-Induced QTC Prolongation in Adolescents. Certain medications frequently prescribed to adolescents can prolong QTC. These include antibiotics, such as erythromycin and azithromycin, antipsychotics including risperidone and haloperidol, antiarrhythmics, and some antidepressants. Risk factors include electrolyte imbalances, particularly hypokalemia and hypomagnesemia, dehydration, and polypharmacy. This module will show you how to quickly check whether a drug prolongs QTC using resources such as Credible Meds. We will also examine a case study of an adolescent started on erythromycin with a borderline QTC and walk through the appropriate decision-making process. Module 6 – Clinical Scenarios and Decision-Making Practice. This final module brings learning into real-world practice with case examples. Case 1. A teenager presents with syncope and QTC of 470 milliseconds. What is the safest next step? Case 2. A 14-year-old girl on antidepressants has a QTC of 480 milliseconds. Should you escalate immediately or monitor? Case 3. A 16-year-old athlete presents with borderline QTC but no symptoms. Is discharge appropriate? Through these examples, you will apply escalation frameworks, weigh risks, and build confidence in making clinical decisions. Learning outcomes. By the end of this course, you will be able to explain why QTC measurement is essential in adolescence, correctly apply and compare QT correction formulas, identify age and sex-specific QTC thresholds, recognize clinical red flags requiring escalation, understand which medications prolong QTC in teenagers, apply a structured and safe approach to QTC interpretation, CPD course assessment. At the end of the course, you will complete a short assessment covering QTC correction formulas and their limitations, normal versus prolonged QTC thresholds, recognition of drug-induced QTC prolongation, real-world escalation pathways. This assessment ensures you can apply knowledge safely and effectively in clinical practice. Certificate and CPD credit. On successful completion and passing of the assessment, you will receive a digital certificate of completion. This certificate confirms 2 CPD hours in pediatric and adolescent ECG interpretation, QTC recognition, and management.